All right, so we'll go ahead and get started. I am really excited to introduce to you today. You guys may have seen Donaldson around some of our meetings lately. Um, and he probably, I don't think he knows this, but uh, I'm particularly excited because Donaldson and I both went through the Department of Health Behavior at UNC, where I did my master's, and he did a postdoc, I believe. So glad to have be among my people. Um, and he's a professor of public health who is spending some time here with us at Gemini, which is really exciting. We have a lot of intersecting interests that you'll see for the group. And I think that'll be on display with what Donaldson is presenting for us today, which is uh, a pretty interesting HIV screening and intervention program um, for a special population that I'm sure he'll tell you all about in Tanzania. So really excited to hear your presentation. And without further ado, you may take it away. Welcome.
Thank you. Thank you very much, Ashley. I do remember now that you mentioned you were at UNC when I was there as well. So it's great. Thank you for nudging my memory. And I'm going to start sharing the slide and take it away. And thank you again for having me. Let me see. Can everyone see the slides? I'll go ahead and put it in sharing mode. Can you see the next slide also coming up, or is it just me?
Yeah, it's giving us
Can see.
the presenter view.
Okay.
So,
Let me try some. If that will work.
that's better.
Okay. Well, good morning, good afternoon, everyone. I'm I'm happy to have the opportunity to share a little bit about work we've been doing in Tanzania. And the main goal I have for today's presentation, especially since it's for the Gemini group specifically, is just to provide an overview of the work that I've been doing in Tanzania for the past decade or so, and provide some context for the current project that we started about a year ago, focusing on providing HIV self-testing combined with community-based follow-up services in the community by nurses who are helping to reach individuals who test at home or in the community to provide them with HIV treatment if they are HIV positive or HIV prevention pills such as PrEP, which stands for pre-exposure prophylaxis. And for those of you who don't know, PrEP is given to individuals who are considered to be at risk for HIV, but may not necessarily. It could be a person who has a partner who is living with HIV, who is on HIV treatment, and they want to maybe engage in unprotected sex. So PrEP has been identified as a prevention method for individuals who do not want to maybe use condoms. So this is part of the component of the work that we are doing now. So the problem that I've been focusing on addressing for the past decade or so is increasing HIV status awareness among men, particularly heterosexual men in sub-Saharan Africa, because for a long time, and this was demonstrated here by this graph from the UNAIDS Joint United HIV programs, where they collected data from multiple countries in Africa. And consistently across multiple countries, men represented here in the light blue or green, if you might say, were less likely to be aware of their HIV status compared to women who are in the orange. So this data really gave a multi-country level representation of what was happening in terms of HIV testing among men compared to women. And the reasons why I became interested specifically was in Tanzania, when I was a PhD student, way before I went to University of North Carolina, the data was very limited in Tanzania, but eventually there was data also showing the same pattern existed in Tanzania, whereas men, again in blue, compared to red, to women in red, were less likely to test for HIV and therefore to know their HIV status. And the reason why HIV testing is important, I'm sure many of you are aware of this, but if a person is or has acquired HIV and they don't test for HIV, then they are less likely to start HIV treatment, which is considered here as part of the HIV care continuum. They're less likely to link to care, which is starting HIV treatment. And if they are less likely to start HIV treatment, that means they're more likely to develop full-blown AIDS, and that's what leads to death in many cases because the individual's immune system can no longer fight the virus. And it's now sometimes very late when a lot of people get tested for HIV, especially among men. So we have seen from multiple countries that men were probably still more likely to die from HIV, not because HIV itself is a killer only, but because they are less likely to get tested for HIV, to know their HIV status, and then eventually get on treatment. And then also to stay on treatment. So this issue was becoming very apparent, especially in the 2018. So you see this data from Tanzania. The last um, bar graph here is from 2017. But shortly after 2017 and 2018, the global community started to pay attention and try to develop programs that would focus on reaching men, because initially most of the funding was targeting women, and for good reasons, given the general gender norms and other economic issues that place women at risk for HIV. But if the men were not being reached, then it was not really a comprehensive approach to targeting, to try to reduce HIV transmission. And one of the strategies that was exciting to come on the market was HIV self-testing. And HIV self-testing was first approved in 2012. And the reason why at the time it was very exciting was because prior to HIV self-testing, individuals had to go to get tested either at a clinic, or even if it was in the community, they had to interact with a healthcare provider to take their blood, and sometimes wait for 20 minutes before they could receive the result, or wait, a couple of days. So HIV self-testing is an oral swab kit that people can use to test for HIV at home. It was, again, first approved in 2012 in the US, but it took a long time before there was any actual support to roll out HIV self-testing. And one of the exciting facts was that if people can test for themselves at home, then they wouldn't maybe let the fear of going to get tested at a clinic, or the stigma that maybe someone might see them and share that they saw them getting tested, or if the nurse finds out that the person is HIV positive, sometimes that information was also shared in the community, and that was a confidentiality issue. So there was a lot of positive reactions to HIV self-testing, but at the same time, there was a lot of hesitation, and one of the main hesitation was that if someone tests for HIV at home and they actually are diagnosed with HIV, then what would the person do in terms of potential harm to themselves or to others who they may have believed, who may have given them the virus. So there are a lot of implementation science questions related to how to really maximize the evidence for HIV self-testing, given that some of the benefits were very clear. But before HIV self-testing could become the standard of care, they needed to have a lot of policy changes. So many countries, all the countries didn't have at the time, a policy to support the integration of HIV self-testing into healthcare practices. And the reasons for not having a policy was, of course, the fact that HIV self-testing was new at the time. And then eventually there were limited country-specific feasibility data. So, for example, just because, like we have with COVID-19, we can think about COVID-19 vaccine, maybe, for example, or another kind of COVID-19 testing. When it became available, it was not yet necessarily, it didn't necessarily have all the support to integrate it into standard of care until there was a lot of push for, from government and other agencies to make it either free or eventually to make it, recommendation or mandatory. So for HIV self-testing, approved in 2012, it took at least the United States up until 2020 to make HIV self-testing part of their standard of care with funding from the CDC as well as the National Institute of Health. But and other questions beyond the policy and country level barriers were related to now the facilities as well as the individuals in the community. Would they be interested to roll this out after it becomes part of policy? Would the healthcare providers receive the additional support that they need? And then would the people eventually use the self-test kit if they receive it? And the remaining questions now are, how do people who self-test for HIV at home continue to receive the support that they need if they don't want to return to the clinic for a follow-up HIV testing or for HIV treatment or prevention? So in Tanzania, I developed a research program that was designed to address some of these questions that I shared earlier, including how to, work with government to eventually support policy change for HIV self-testing. And then eventually, as part of the phase 3 of my research program, thinking about ways to provide those additional follow-up services in the community. But as I mentioned earlier, this program really started back when I was a PhD student, before HIV self-testing was on the market, where I was interested in mainly learning about why men were not getting tested for HIV, and then eventually using data from Muhimbili University in Dar es Salaam as part of phase 1 of this research project. So building on this collaboration that I started with colleagues at Muhimbili University back, starting in 2009. I've then eventually been able to build on that to incorporate HIV self-testing, and then eventually thinking more about ways to link people to care. So this is just a brief example from the one project from phase 2 of this research program, where with funding from University of North Carolina Center for AIDS Research and the NIH, as well as PEPFAR, I was able to develop the self-testing. Well, the self-testing education and promotion intervention was mainly funded with support from University of North Carolina Center for AIDS Research and then the NIH. And while I was working on this self-testing project, the STEP project, I learned that from engagement of Ministry of Health and implementing partners such as JPIGO, that they were also implementing a countrywide HIV prevention program that was going to eventually include HIV self-testing. So the first article is from the formative research we conducted with men in Dar es Salaam back in 2016 to learn what their perceptions were toward HIV self-testing in general, because this was new, it was not yet in the country. So we wanted to just learn, okay, do you know about HIV self-testing? And then if you don't, we provided them with a brief explanation of what HIV self-testing was. And then after that, we asked them, is this something that they would be interested in using? And then if they had any recommendations on how we should implement an intervention on HIV self-testing, as well as a name for the project So even though the English name of the project is STEP, but the name that the men provided when we did our interviews with them was Mate Yako Afia Yako, which means your saliva, your health. And the reason why the saliva part is in the name is because, as I mentioned earlier, HIV self-testing is an oral swab that you use, to collect a sample of your saliva, and then eventually you can receive your results in 20 minutes. So that's the name that they gave for the project. So we used that name when we conducted the eventual pilot intervention. And the Saudi project was important at the time because, as you know, you're all familiar, as you all may be familiar with, the difference between a research project and a program. So my project was limited to just Dar es Salaam at the time. But then when I engaged the Ministry of Health and eventually was able to make connections with the team that was implementing the Saudi project, then as you can see here in the second paper, they were reaching way more men. So for example, in our STEP project, we only initially reached 31 men for the qualitative data collection, and then eventually 200 men in the intervention and 200 in the control group. But then with the Saudi project, they had a much wider reach, reaching more than 1 million men in the country. And then as part of the men that they were reaching, they also incorporated the same intervention strategy for HIV self-testing to collect country level feasibility data for HIV self-testing. So the components of the STEP intervention combined with the Saudi intervention included engaging men or other groups for the other groups that the Saudi project was reaching. So, for example, my focus was on heterosexual men, but Saudi was also engaging female sex workers and men who have sex with men, adolescent girls, and young women. But for our focus, again, we engaged men and trained men as peer leaders. So we provided a 5-day training on HIV self-testing. And then as part of that 5-day training, on the third day, we asked the men to go to the community to engage their friends, talk about HIV self-testing, and find out what the issues, what are some of the issues that their friends were reporting to them when they talked to them about HIV self-testing, to try to encourage them. And then eventually, after this peer-led promotion of HIV self-testing, those peer educators would then ask their friends to come to a tent site where a nurse would provide the HIV self-testing kit to the men and additional information as they enroll in the study. And then, of course, the goal is to increase uptake of HIV self-testing, but also to assess whether the men would be able to use the HIV self-testing kits and understand the instructions. Because if you don't follow the instructions properly, then you might get the wrong result, and you might think maybe you're HIV negative, but maybe you actually, you have HIV, but you just didn't follow the instructions properly. So those are very important. And this intervention, based on the fact that we're able to work with the Ministry of Health and also the community level, was informed by the social ecological model, as you can see here, starting at the individual level, providing knowledge to help raise awareness about HIV self-testing, and then eventually to help change the attitudes and skills towards HIV self-testing, and then eventually engaging the networks of men through the peer educators who are also working with us at the organization by having nurses who are coming from the healthcare facilities to also work with the peer educators to then create this wider community level awareness of HIV self-testing, but also providing support and connecting nurses to come in and deliver these kits with the ultimate goal of providing the country level data that was needed to change the policy towards HIV self-testing. So I've talked a lot. I know pictures usually are more powerful. So on the left here, we have the tents that were used in the community, in the neighborhoods where the peer educators would bring their friends to the tent sites to receive the HIV self-testing kits from the nurse and then also the research assistant was at the tent to also help collect the baseline survey from the individuals who agreed to enroll in the study. And so in this picture on the right, the lady is the nurse, and then the young man with the red shirts, the three red shirts, and then also these two men here were a group from the peer educators that we had trained who did the demand generation for us and also promoting HIV self-testing. And then we had three students who traveled to Tanzania to partake in the project. One undergraduate student, and then two graduate student, one PhD and one master's students who were in the field during that summer. This was summer of 2019. So briefly, the data from the pilot stage to assess the feasibility of HIV self-testing. We have 35,000 individuals who were reached to receive HIV self-testing throughout 11 regions in Tanzania as part of, again, the combined effort between the project, the STEP project and the SAUTI project. And the majority of individuals decided to actually receive assistance on site and conduct the self-test kit nearby the tents. And then some of them decided, they didn't need any assistance, and then the lower percentage of them decided that, they didn't want to stay near the site. They would just collect the kits and take it home and use it there. And in the first on-site, so for the individuals who received assistance and conducted the self-test on-site, there was a 5% rate of individuals who were diagnosed with HIV. And to bring your attention to the yellow part of this data is we see that there's a high level of individuals, even though they were on site, they may have used the test on site, but we still provided them with the privacy for them to decide, whether they want to come back. And when I say on site, I don't mean exactly in the tent. So they could, take the self-test kit, receive the assistance as needed, and then decide to go maybe to the next tent because we have two tents, as you can see in the picture. So after they finish using it, they could decide to leave without coming back and talking to the nurse. Again, trying to emulate the privacy and autonomy that someone would have if they decided, to go use the test at home and didn't want to engage with a healthcare provider. So the fact that we had a large number of individuals who were untraced, meaning after they used the test kit, they decided to not engage with us or reach out by phone, left some lingering questions for me as a researcher, and also, of course, for the program in Tanzania, which I will talk more about in the next few slides. But the main focus of this part of the project, and also, for the government, was not necessarily to trace people when they are using the self-test kit. It was to figure out how best to promote it, how best to make sure that if it's given, will people be interested in it? And that's more, and how to really roll it out in the country so that they could have country level specific data that eventually contributed to the government changing the policy in December of 2019 to include HIV self-testing as part of their standard of care. And as part of this policy now that was changed in 2019, there was a national campaign that was launched in Tanzania called Furaha Yangu. And Furaha Yangu, for those who don't speak Swahili, means my happiness. And this was part of the efforts to reach men specifically for HIV testing. And the reason why this was monumental is because the campaign, the Furaha Yangu campaign, was launched initially in 2018. But when it was first launched, HIV self-testing was not included in that national campaign. So after the projects on HIV self-testing, where the country now had specific data to determine how best, to roll out HIV self-testing, then they included HIV self-testing in the campaign and started to promote it so that men could become aware of this new way of getting tested for HIV. So currently in Tanzania, HIV self-testing is part of, standard of care, not just for men. Individuals can receive it if they go to a healthcare facility, and maybe also able to buy it at a pharmacy. But as I mentioned earlier, there are some limitations as well, and I'll talk about some potential solutions. So one of the limitations is the fact that as part of the HIV care continuum that I mentioned earlier, a person getting tested for HIV is only the first step. The next steps of making sure that the person receives linkage to HIV treatment or HIV prevention pills such as PrEP is also just as important. And there was many of individuals who may have returned to the sites, but at the time when the HIV self-testing project was being piloted, the nurses were only responsible for providing the HIV self-testing kits. They were not responsible for providing the follow-up services. For example, for the individuals who were diagnosed with HIV, they had to be referred to the facility to get HIV treatment and also confirmatory HIV testing. But in thinking about what additional services the nurses could provide, and also leveraging evidence from Malawi, where they conducted an HIV self-testing study, but then they had the nurse trained to actually go and provide confirmatory testing as well as deliver HIV treatment to the client's home. So the clients didn't have to come to the facility at all at the time. And this study was actually published back in 2015 or so. So it was a very early trial to show how not just to provide HIV self-testing, but how to provide those additional services. But again, at the same time, as we know, evidence from a study does not mean that countries and healthcare organizations are going to make it part of their standard of care. So I became interested in replicating this similar approach in Tanzania. And thankfully, at the time, after we conducted the self-testing pilot study, the Tanzania Ministry of Health also launched a program where they were now training nurses to provide HIV treatment. And the reason why this was significant is because only primary physicians or clinicians could enroll someone on HIV treatment before this program was launched, called the Nurse-Initiated Management of ART program. So combining this new program and our feasibility data on HIV self-testing, I was able to secure a grant where we propose to conduct what I'm calling now the Step Plus community-based NEMARC program or intervention. And essentially the main difference is that we are moving beyond just providing HIV self-testing and working with the nurses to help provide those additional HIV services in the community, as opposed to relying on just a clinician at the facility or sending someone to the facility. So briefly, the aims of this new project are first to finalize the intervention components, and by intervention components, I'll share in the next slide what we propose for the intervention to look like. But at the same time, we need to work. We have been working with different stakeholders to help finalize those components. So for the first aim, it includes conducting additional qualitative research to address multi-level barriers that could prevent us or facilitate us from, to deliver this intervention in the community with nurses. And in aim 2, we want to evaluate the effectiveness of this intervention approach on different outcomes, which I'll share eventually. But the main outcomes are whether individuals will start HIV treatment or PrEP after their self-test in the community. And then we are using a hybrid type 1 cluster randomized control implementation effectiveness studies design, or at least that's what we propose. And the reason why I'm saying that's what we propose is, we wrote this grant back in 2023, and a lot has changed in the field. So we may need to change our design a bit as we get ready to evaluate the intervention. And then the last aim is to evaluate, the potential facilitators and barriers after we have evaluated the intervention, so that we can inform its scale up in the country potentially. And we are working closely with the NEMAT program, as I mentioned. And the reason, again, I think I'm very excited about this project is because of the fact that we have this direct engagement with somewhat of a new program in the country, and trying to see how best to leverage that program for this project. So as you may remember, earlier when I shared the intervention component for the STEP project, it only had really 3 components: peer-led promotion of HIV self-testing, and the nurse distribution, with the goal of increasing HIV testing. So for the current project, it has more components, still working at the promotion level, but this time we are, instead of working with peer educators, we are working with community health workers. And the reason was because community health workers are already trained and integrated into the healthcare system, and working very closely with nurses already to do regular HIV services, or malaria, or other health topic. And then the second component is still working with the nurse to help do the distribution. And this might be vice versa. Community health workers can also do the distribution of HIV self-testing. But the reason why we are, again, continuing to engage with nurses is, again, we're working with the NEMAT program, as well as wanting to make sure we have that additional support if needed. And then in addition to distribution, the nurses can provide the follow-up confirmatory testing in the community, and start individuals on PrEP or ART if needed. And then eventually the nurses can also do follow-ups in the community to deliver the PrEP or the ART pills for our clients. At least that's what we propose in the proposal. But as we have been doing the activities for AIM-1, we have been learning a lot of information that is kind of informing some changes that we are considering making. So the setting for this new project is in Arusha. We decided to work in Arusha City Council, in particularly 6 districts in Arusha City Council, and we are reaching a different group of men, at least different in the sense that in the original STEP project, we only work with social networks of men who were just regular neighborhood residents. And that was based on a larger project my mentor at the time was doing in Tanzania. So for this project, I was interested in reaching men again, but thinking about how to reach a different group of men. And motorcycle taxi operators, or as they are known in Tanzania, Boda-Boda drivers, or piki, represent a large network of men, not just in Tanzania, but also in other countries in Kenya, and maybe even outside of sub-Saharan Africa. The motorcycle public transportation business has really increased over the past several years, and many of the men in that industry, whether it's the motorcycle taxi business or the other type of transportation businesses, are very mobile, and due to their mobility of moving from different parts of the city or different parts of the region, they are interacting with a lot of multiple ladies, and having multiple sexual partners. And also at times do have maybe transactional interactions, in the sense that maybe they have a client who they may know, but maybe sometimes the client may not be able to pay. So sex can maybe sometimes be part of the way they receive their compensation. And they may also have their own primary partner at home, and condoms are not always involved, right? So there's these different multiple sexual networks that they have that place them and also their networks at risk for HIV. And prior to, I think, motorcycle taxi operators and the other taxi businesses, a lot of the focus was on long distance truck drivers. And that was very clear because, again, they're going from different side of the countries, from country to other countries. But there are these other groups of men who are just as maybe at risk, but were not as included in previous approaches. And then the other reason I was interested in working with Boda-Boda riders or operators is because there are no study that I've seen that have evaluated or that has conducted a randomized control trial to look at different intervention strategies to reaching them and also providing support for follow-up services. So briefly, this is just an overview of what we have achieved so far from year one of the project. We were funded June of last year. And as part of the activities, we've done a lot of engagement with different national and regional stakeholders, including Ministry of Health, district medical officers, regional medical officers as well, just to inform them about the study, but also to find out what similar programs that may have been happening that we may not be aware of, so that we make sure that we don't duplicate efforts, by providing the same services and calling it an intervention, whereas maybe that may be already happening in the community. So in addition, we did hotspot mapping, which included having the community health workers go into the community to identify different locations where the motorcycle taxi operators were based. Because in Arusha and similar to other settings, the Boda-Boda drivers have specific stations where they become a member, and they are usually a member of that station for a long time. So we wanted to identify as many of those stations as possible, and then eventually also look at which of those stations were considered to be a hotspot station. So meaning they have maybe they are located near a bar. They also may have maybe ladies that they are interacting with in that station, or maybe there's a high rate of substance use. So all that information was collected with the help of the community health workers who were already known in the community. And then we also conducted qualitative data collection to find out from some different stakeholders their perceptions of the intervention and potential strategies. So as I mentioned, one of the key things that we focused on was to, again, find out what potential barriers and facilitators could play a role for the intervention. So we are relying heavily on the Consolidated Framework for Implementation Research, which is very heavily used in the implementation science field, but usually it's used at the end of a study. So after the intervention has been implemented and evaluated, they usually use the CFIR to assess implementation barriers and facilitators, whereas we are using it pre-implementation to look at what how the different domains, and for those who are not familiar, the CFIR has several domains that allows teams to explore what outer setting factors may influence an intervention. So in our case, thinking about, again, policy level issues that we may need to be concerned about in terms of if the nurses now were not trained to provide HIV treatment and there was no policy in the country, we would not be able to necessarily roll it out unless we have special permission to work with nurses to give treatment if they were not yet already part of that program. And then we have also inner setting the inner setting domain that helps us to explore issues related to the organization, the inner setting of the organization, such as the health facilities, where we have to rely on the health facilities for the drugs that we would need to provide HIV treatment or prevention, as well as making sure that there's enough staffs at the organizational level. And then eventually, again, think about the individual level domain as part of the CFR, thinking about both the healthcare provider team, but also the men that we are trying to reach. So looking at the factors that would influence both their participation, getting the nurses to agree to go into the community to do these follow-up services, what additional training that they may need. And then we also have the implementation process domain, which looked at, again, the training, the needs of the nurses, but also the strategies that we need to engage some of the men. But anyway, I'll just share. So some of the activities we've done as part related to the CFR and also just the hotspot mapping is also talking to program implementers and the district medical officers to find out if the government, with funding from PEPFAR, has been doing similar activities. And we conducted several focus groups discussions as part of these activities. So we interviewed nurses. And one of the interesting findings that I'm not going to get too much into, but is that we learned that there were nurses who said they had done community-based ART or PrEP services, but then when we interviewed some of the nurses as part of the focus group, we found out that it was not all the nurses that had been trained to carry out community-based ART or PrEP refill, at least in Arusha City. So there are specific clinics where they had selected nurses to go into the community, receive the training to do those services. Whereas initially, when I was talking to the program at the national level, I just assumed that, okay, all nurses in the country were doing this, but we had to learn specifically, where, those clinics were, so that if we wanted to work with them, and also to not duplicate efforts. We also conducted focus group with Boda-Boda station leaders, so that we can learn from the leaders themselves whether they would be interested in such a project, and then what they would recommend on how to engage their station members. And then the Arusha City Health Management team members as well, since they would be involved in providing self-testing kits as well as support for the community to roll out the distribution and working with the health workers. And then lastly, we found that there was a group, there was a civil society organization in Arusha that was actually rolling out a similar program of community-based PrEP for men. So we, in partnership with this CSO, we were able to reach some of those men to find out what the experiences had been, and particularly what the differences may have been in terms of the service that they're receiving. And the organization, the CSO that I mentioned, was implementing this project under a larger PEPFAR-funded project at the time called EPIC, and EPIC means Epidemic Control for HIV Prevention. It was funded by the U.S. government, and it was being implemented in different countries, but in Tanzania, it was being implemented in those regions where you see that are in orange. And initially, they were focusing on reaching female sex workers, men who have sex with men, vulnerable adolescent girl and young women. And then more recently, in October 2024, they started to reach heterosexual men with new funding and new support. So this, to us, was a very good thing, but also it meant that what we were planning to do in our intervention, that was now being done by this larger program in the country. So we had to keep thinking about what would our intervention be if now there is a selected group that is also providing similar services. You know, do we go to another side of the city to do our project, or do we maybe improve our intervention to add to it, or change the design altogether? And the name of the organization that was conducting this similar program, let me just make sure, how am I doing on time? Okay, let me check. How much time do I have left?
Yeah, we're a little over time, so if you want to get to the final points, that'd be great.
Okay, thank you. Let me just move forward. So
Loving the
essentially,
presentation, but just a little short on time. Yeah.
yeah, no problem. So essentially, we interviewed those men to explore their perceptions toward the services that they're receiving, and the qualitative data organized by the domains of the CIFER reveals that. So the men who were receiving community PrEP initiation were not just receiving it as an individual. So this organization created groups to help promote the PrEP uptake. Instead of the nurse going and working with one man in the community, they decided to have the men form a social support group so that they could be more interested in taking PrEP. So one of the men responded that, you know, first being part of the group helped them to not fear the stigma, because, you know, you realize the user is not just me alone. There are many of us in the group. And also when using PrEP for the first time, there are different side effects like headaches or nausea. But after joining a group, it helps to easily ask others, because they are also users as part of that group. It also helps to remind them about taking the medication and providing, again, that overall support. So I won't get into all the results. I'll just kind of move forward to some of the key recommendations for implementation. So one of the recommendation is the phase approach that the men kind of recommended, to not just go out and roll this intervention out, but also to think about doing the promotion, which we already had in mind, engagement, using different strategies, not just community health workers, but looking at how to use social media, as well as other events in the community, such as concerts that are usually organized. And then eventually think about sustainability. So thinking about how best to leverage either existing infrastructure to help roll out the intervention. And then our future plans for the project includes, again, going back now to work with the Ministry of Health and the regional medical officers, because as you are all aware, or maybe aware, the government funding cuts from the US has affected a lot of the plans and programs that the governments were implementing. So initially we had identified 174 stations, Boda-Boda stations, and randomized them with 38 stations to receive the intervention, and 38 stations to receive the standard of care, with the primary outcomes including PrEP initiation, as well as retention on PrEP over time. And then also looking at whether men who are on PrEP acquire HIV eventually, and then those who are on treatment have a viral suppression. And what, you know, for the purpose of the GEMINI group, what I'm, you know, hoping to develop is really a sub-project that could help to maybe assess injury preventions among Boda-Boda drivers, looking at the general visit to emergency departments, if they do go, what are they going for. I know for one of the topics that came up from our interviews was the fact that there were a lot of injuries, accidents, or just weather-related injuries that was creating some concerns among the men, and then eventually, you know, to see what interventions could be used to help address some of those issues. So I'll stop there, Asante Sana, and hopefully there are some, you know, there's time for questions if there are any.
Thank you so much, Donaldson. Really, really interesting work going on. Feel free to put in the chats if folks have questions, or you can unmute. We'll just take a couple of questions for the sake of time. This is a great work. I see that I was curious as we were talking about it, about HIV self-testing in other countries and states. So we kind of had that side conversation going. Gabby shared about Brazil, and I shared some things in the US. But Miriam asked, why did you choose Arusha? given the transmission rates are lower compared to some other regions?
Thank you. One of the reasons I chose Arusha was because the regions where there are higher HIV rates have been kind of saturated with research. So Dar es Salaam, there are a number of organizations engaging in research already. You have MDH, you have, so like Muhimbili. But when you look at Arusha, there is very little publications from Arusha from randomized control trials. And then you also have, Moshi is already again saturated with researchers. So I was thinking of a ground where there might not be too much research taking place, but also to have data from that area, because when a project or when a program becomes standard of care, it's supposed to be rolled out, in the whole country. So working in an environment where there may be less activities could provide that additional data from that area.
I think that makes sense. Any other questions or comments for Donaldson?
Hi, Donaldson.
Hi, hello, Beatrice.
Go ahead, Beatrice.
Okay. Great presentation. It's very important, our results. So we conducted a qualitative paper in Brazil about the perceptions of nurses. But like Gabby said, we have self-testing for free in Brazil. So in primary health services, there are available to the community, but the nurses spoke to us the overload of the service in health primary, and also she said to us they is very overburdened to include another activity in their daily routine. So to us, it's important because despite exists technology to fight against the HIV, the health education is important to these professionals incorporate these innovations in their practice. So I don't know if it's clear to you, but despite this technology came to helping us to combat against the HIV, we need to think about this problem in our service. So
Thank you, Beatrice. If I understand correctly, the concern from the nurses is the fact that they already have a lot of responsibilities, and adding self-testing distribution to their workload is going to be overburdening them. And I
it sounds like
agree.
not only sorry, Donaldson, it sounds like not only the self-testing distribution, but also the education that's going to come with it, right, Beatrice? Yeah.
Yes, and I can talk for in Tanzania. I know the community health workers have been engaged heavily to help reduce some of that burden. And I don't know in Brazil what other teams that are supporting the healthcare system that could be engaged. And you have also in the earlier project, we engaged peer educators. So I think different health systems in different countries, will address this differently, but at the same time, those are not reasons perhaps to not provide this, additional tool for people to get tested for HIV. And I know in the US, for example, people can go and receive the self-test kit away from the healthcare facility. So thinking about, different distribution locations as well. A pharmacist, could provide it in minimal information, or videos can help, with self-testing kit. I see we have a question from Ivan Terry. Hopefully there's, time for one more.
Yeah, just a quick one. Thanks, Donaldson, for a great presentation. Just two quick questions. One is you talked about, the implications of the funding landscape, but just long term, where does the Tanzanian government see self-testing and how it's funding it in a sustainable way? And the second question, you were in Tanzania recently, and I'm seeing a lot of waves in the digital space, AI space in Tanzania. What are there any intersections with that work with future self-testing initiatives? Thanks.
Thank you. The funding for self-testing, from what I was told, is it comes directly from the Tanzanian government. So the PEPFAR cuts, when I say the Tanzanian government, whether they're receiving it from global funds or another location, I'm not sure, but the cuts that happened recently did not affect the distribution of HIV self-testing. So perhaps that's still part of the current PEPFAR funding or another source of funding. The digital space is definitely something we are working on. I have a PhD student from Tanzania who has focused his dissertation on exploring how digital intervention can be leveraged to support distribution, also follow up for confirmatory testing or ART. The next step we are planning to work with, there's one clinic in Tanzania that we are engaging. They already have a platform, a mobile online platform that they're using. There's an app that they're providing consultation. So we are planning to work with them to see if they'll be interested in incorporating HIV self-testing services as part of that digital space. So stay tuned.
Thanks.
Thank you. And thank you so
All
much
right,
for having me again. Sorry for going over.
No, that's okay. Thanks, Donaldson. Join me in thanking Donaldson, congratulating for a great presentation. Thanks so much.